Hello again. This is Dr. Dakanay, and today we will be learning about the disorders of the pleura. So this is found in chapter 288 of your Harrison's. The learning objectives for this lesson are first to recall the anatomy and physiology of the pleural space, to discuss pleural effusion, which is grouped into your transudative and exudative effusions, and third, to discuss your pneumothorax, which includes spontaneous, traumatic, and tension pneumothorax. So first, let's recall the anatomy of the pleural space. So you have the two layers of pleura, your outer layer, which is called your parietal pleura, which is adherent to your chest wall, while the inner layer is your visceral pleura, and it is adherent to your lung parenchyma. And in between the two pleura is your very small space called your pleural space. Okay. The normal pleural space is only 18 to 20 micrometers, so it's very small, but still a real, not potential space. And the purpose of your pleural membranes is to allow extensive movement of the lung relative to the chest wall. So inside the pleural space, you have a thin layer of fluid acting as a lubricant to prevent friction between your visceral and parietal pleura. So the fluid in the pleural space mainly comes from the capillaries in the parietal pleura, but may also come from the interstitial spaces of the lung via your visceral pleura and even your peritoneal cavity. The first condition which we will encounter in the pleura is your pleural effusion. When we say pleural effusion, this is the presence of excess fluid in the pleural space. And it can either be due to an increased entry of fluid or both an increase in entry and a decrease in removal by the lymphatics. So normally, your pleura can actually remove the pleural fluid if it's less than 20 times the normal value. But if it's more than 20 times the normal value, then that's the time that pleural effusion occurs. And this is commonly seen if you have both an increased entry and a decreased removal by the lymphatics. So symptoms of pleural effusion would be first your pleuritic chest pain. Pleuritic meaning if the pleura is stretched, such as during deep inspiration or during coughing, then that's the time that your patient will experience that chest pain. And this tells you that there is inflammation in your parietal pleura. Now, take note, it's only the parietal pleura that has your pain receptors, which is why we know that the parietal pleura is involved when you have pleuritic chest pain. Next, your patient can have cough, and this is due to the compression or distortion of the lung itself. So the distortion of the lung structure causes the coughing in these patients. And last, you have dyspnea or shortness of breath, and this is caused by the mechanical inefficiency of your respiratory muscles. Remember, your pleural effusion is space occupying. It pushes on your lungs, it pushes your chest wall outward, and it pushes the diaphragm downward. So the pushing of the chest wall and the diaphragm will lead to stretching of the respiratory muscles. So if you remember, your muscles should have significant overlap of your muscle fibers so that you can have proper muscle contraction. And if you stretch your muscle fibers, then you don't have that area of position for which the muscles can contract adequately. Okay. So how do we know that the patient has pleural effusion? The first diagnostic to request would be the chest x-ray, which is usually taken in both the posterior-anterior view as well as the lateral decubitus view. So what do we look for in a patient who likely has pleural effusion? We check for presence of a homogeneous opacification. So homogeneous meaning it's the same all throughout. Opacification meaning there is whitening in your chest x-ray. And we also check for the meniscus sign. So meniscus sign tells you that the fluid has a tendency to go up the container. So the fluid in your pleura goes up the pleural space. So that is your meniscus sign. And we also request for a lateral decubitus film to see the leveling of the fluid on the lateral decubitus position. And if your fluid is more than 1 centimeter on lateral decubitus, then these patients are usually advised to undergo thoracentesis. Okay. So next diagnostic to request would be a chest ultrasound, which is actually now the standard for diagnostic for pleural effusion. So it's very helpful. First, we can get the volume of the pleural effusion. We can also check for the presence of floculations. And chest ultrasound can even guide or map the thoracentesis during the procedure. Okay. Another option would be to do your VATS, video-assisted thoracoscopic surgery or thoracoscopy. And the last option would be to do an open surgery or open thoracotomy. So as mentioned, if you have a significant amount of pleural fluid, then your patient might have to undergo thoracentesis. Thoracentesis is the removal of your pleural fluid using a small bore needle. It's a relatively safe procedure and is said to be safely performed even if your patient has any coagulopathy, thrombocytopenia, and even on patients on mechanical ventilation. So thoracentesis can either be diagnostic, meaning we just get the fluid to send it for pleural fluid analysis. But most of the time, thoracentesis is therapeutic, meaning we try to relieve the patient's difficulty of breathing by removing that fluid in the pleural space. Okay, complications are rare. You can have pneumothorax in up to 4 to 5% of cases. So air in your pleural space. Or also, very rarely, you can have hemothorax or bleeding into your pleural space. So once you do your thoracentesis, you can now try to determine the type of pleural effusion. Is this an exudate or a transudate? Transudative effusions are usually caused by systemic factors, such as if you have congestive heart failure or chronic kidney disease, while exudative effusions are usually caused by localized problems or lesions, such as your malignancy, infection, and other localized diseases. So to determine if your patient has an exudate or a transudate, we send the pleural fluid for analysis and use the Lights criteria. Okay, so for the Lights criteria, you have the following. So first is you get the protein ratio. So you divide the pleural fluid protein by the serum protein, and if the ratio is less than or equal to 0.5, then that's probably a transudate. If it's more than 0.5, then that is likely an exudate. Second is to get the LDH ratio. So again, you divide the pleural fluid LDH by the serum LDH. And if the ratio is less than or equal to 0.6, then that is a transudate. If it's more than 0.6, then this is likely an exudate. And the third criterion is if your pleural fluid LDH is less than 2/3 the upper normal of your serum, then that's a transudate. If it's more than 2/3 the upper normal for serum, then that is an exudate. Okay, so to label the pleural fluid as an exudate, you need only satisfy just one criteria. So if you satisfy any one of the three criteria, then this patient's fluid is labeled as exudative. Okay. However, take note that your Light's criteria can actually misidentify around 25% of transudates as exudates. So if you met the criteria for an exudate, but you are um, more or less sure that the patient has a condition that produces a transudate, then you can try to compute the following. You subtract the pleural fluid protein from the serum protein, and if the difference is more than 31 grams per liter or 3.1 grams per deciliter, then that is still a transudate and not an exudate. So other tests that we request when we're doing pleural fluid analysis is the description of the appearance of the fluid, the glucose level, differential count, your microbiologic studies, which includes your gram stain, culture, KOH smear, and AFB smear, as well as your cytology. So in your Harrison's, we have there the diagnostic algorithm for the diagnosis of pleural effusion. So when presented with a patient having pleural effusion, the first thing to do is to perform your thoracosynthesis. And when you have your pleural fluid analysis, you can try to determine if any of the criteria for exudative effusion are met. So if you do not meet any of the criteria, then that is a transudative effusion, and you are looking at probably a heart failure, cirrhosis, or chronic kidney disease. Well, if you satisfy the criteria for your Light's criteria, then that is an exudative effusion, and you have to proceed with the other diagnostic tests, okay, such as your pleural fluid glucose, cytology, differential count, culture, the stains, and also the markers for tuberculosis. So for the glucose, if it's less than 60 milligrams per deciliter, then the following are more likely: your malignancy, bacterial infection, and rheumatoid pleuritis. If in spite of doing your diagnostic exams, you do not have yet a diagnosis, then you might consider that the patient is having a pulmonary embolism, especially if your patient has the risk factors for developing PE. So in these patients, we can request for a CT scan to check for the presence of your pulmonary embolism and treat for the pulmonary embolism if present. If not, then you can check for the pleural fluid markers for your tuberculosis. And if you find that the markers are elevated, then you treat the patient for TB. If you still do not have a diagnosis and your patient is improving clinically, then you might just need to observe the patient. But if the patient still is symptomatic or the pleural effusion continues or progresses, you might consider doing your thoracoscopy or VATS or an image-guided pleural biopsy. Okay, so we will be discussing the different types of pleural effusion. So first is your effusion due to your congestive heart failure. So this is actually the most common cause of your pleural effusion overall. No? So if you combine both the transudative and exudative effusions, heart failure is still the most common cause of effusion. This is caused by the increased amount of fluid in the lung in the interstitial spaces which exit across the visceral pleura. So your heart failure patients will have pulmonary congestion, and that congestion will go into the interstitial spaces and exit through the visceral pleura into your pleural space, becoming pleural effusion. So if you're considering that the patient has effusion due to heart failure, then we can request for the N-terminal pro-brain natriuretic peptide, the value of which would be more than 1,500 picograms per ml if this is effusion due to heart failure. Next is your hepatic hydrothorax, which is quite rare. It occurs only in around 5% of patients with cirrhosis and ascites. So this is the direct movement of your peritoneal fluid because your diaphragm actually has very small openings. So ascites fluid or peritoneal fluid can actually cross from the abdomen into your pleural space. And most of the time, your hepatic hydrothorax is right-sided and large in amount. Next, you have your paraneumonic effusion, which is the most common type for your exudative types of effusion. So this can be associated either with a bacterial pneumonia, lung abscess, or bronchiectasis. And of course, the treatment of your paraneumonic effusion would be for the patient to be treated with antibiotics. However, if you do your thoracentesis and you have the following findings, then you might have to proceed with a more invasive procedure such as your closed tube thoracostomy. So in ascending order, meaning the one at the bottom is the most important. So if you have a loculated pleural fluid, if the pH is less than 7.2, so the fluid is acidic, which is a sign of bacterial presence. If your glucose is low, less than 60 milligram per deciliter, again, might be a sign of bacteria in the pleural fluid. Definitely, if you see a positive gram stain or culture when you do your analysis, then you would have to request for an invasive procedure. And also, if you see gross pus in the pleural space, then again, you have to proceed with your CTT insertion. Okay. Another cause is your malignant pleural effusion, and this is usually secondary to a metastatic disease in your pleura. So most of your malignant pleural effusions are caused by the three lesions, your lung carcinoma, breast carcinoma, and lymphoma. Okay. Usually, these patients will have a dyspnea which is out of proportion to the size of the effusion, meaning your patients with malignancy might just have a small amount of effusion but are still seen to be dyspneic. This can be due to several factors, which might include your myopathy. So your patient's muscles, respiratory muscles have become weakened. So your pleural effusion is another problem that leads to the dyspnea, worsening dyspnea for these patients. Okay, so the pleural fluid for these patients is always exudative. And if you have a low glucose level, then that patient will probably have a higher tumor burden. Mesothelioma are tumors that arise from the mesothelial cells that line your pleural cavity. And these cases are usually related to asbestos exposure. So on chest x-ray, you would notice that these patients will have pleural effusion, generalized pleural thickening, and even nodular densities in the pleura, and a shrunken hemothorax. So diagnosis, the patients would have to undergo biopsy of the pleura to determine presence of mesothelioma. Next is your pulmonary embolism with dyspnea as the most common symptom. And pleural fluid for these cases is almost always an exudate. So you have localized factors because of that embolism into the vessels. However, sometimes patients can also have a transudative effusion because patients with pulmonary embolism also develop a form of right-sided heart failure. Next, and very common in the Philippines, is your tuberculosis pleuritis. So your TB pleuritis is actually more commonly associated with primary TB rather than reactivation TB. And this is said to be a hypersensitivity reaction to the presence of your TB proteins in the pleural space. So it's not the presence of the bacteria itself, just the proteins coming from the bacteria which enter the pleural space and cause that hypersensitivity reaction. So patients with TB pleuritis will usually present with fever, weight loss, dyspnea, and pleuritic chest pain. When you do your thoracosynthesis, your fluid will be exudative and very common. No? You would see a lot of lymphocytes. So if you do thoracosynthesis and see a lot of lymphocytes in the pleural fluid, then think always of the possibility of TB. So another diagnostic test you can request if you're suspecting TB in the patient is to request for TB markers, your adenosine deaminase or ADA. So if it's more than 40 international units per liter, then that's a positive result. Or your interferon gamma with a result of more than 140 picograms per ml. Next condition is your hemothorax, which is the presence of blood in the pleural space. So to determine if the fluid is actually blood and not just a sanguineous or bloody type of effusion, we compare the hematocrit of the pleural fluid to that of the hematocrit in your peripheral blood. So if your pleural fluid hematocrit is at least 50% of your peripheral blood, then suspect that the patient is having a hemothorax. So hemothorax is most commonly traumatic, but can also be due to your iatrogenic cases and even non-traumatic hemothorax, such as those in tumors. For hemothorax, if you notice that the pleural hemorrhage or the bleeding is occurring at more than 200 ml per hour, then you might have to proceed with thoracoscopy or thoracotomy. So once we determine that the patient has hemothorax, we usually request for a closed tube thoracostomy. And if we see that the CTT output is more than 200 ml per hour, then this patient will need to undergo surgery for the closure of that bleeder. Other tests, you can look at the gross appearance and even the odor of the pleural fluid. If the fluid smells like pus or has a rotten smell, then consider a bacterial infection. Obviously, if it smells like urine, then that is probably a urinothorax. Again, if it's bloody and the hematocrit is more than or equal to 50% of the peripheral blood, then consider a hemothorax. And if the fluid is turbid or cloudy, we send the fluid for centrifugation. And if after centrifugation the fluid clears up, then the turbidity is only due to cellular debris. However, if your turbidity persists even after centrifugation, then you have two possibilities, your chylothorax and your pseudochylothorax. So if you remember, chyle is actually the fluid which contains your fats, your triglycerides, which were absorbed from your intestines. So because of the large molecules of fat, they cannot enter into the circulation immediately and pass through the lymphatics, eventually passing through the thoracic duct. So the problem is if your thoracic duct is disrupted, no? If it was cut, for example, during your bypass surgery, then you can have leakage of your chyle into the pleural space. So this is an acute process since this is just trauma or disruption, and therefore your pleural surfaces will not be thickened. You also will not find any cholesterol crystals. What you will find is your triglycerides. No? So the content of your chyle is mostly triglycerides, so you expect that the triglyceride level of your chylothorax will be elevated. In contrast, your pseudochylothorax is actually a chronic disease process. So if you have a prolonged pleural effusion, such as in tuberculosis, then this this can lead to pseudochylothorax with a thickening of pleural surfaces and presence of your cholesterol crystals. So obviously your pleural fluid triglyceride will not be elevated in these cases since this is not really chyle fluid. Okay, so for chylothorax, since this is a disruption in the thoracic duct, then the goals of management would be first to maintain adequate nutrition and reduce the volume of your chyle, so thereby decreasing the volume of your pleural fluid. So we manage this by changing the diet of the patient. No? We give the patient your smaller or medium chain triglycerides or give total parenteral nutrition. Or you can give the patient octreotide, which is a somatostatin analog. It causes vasoconstriction of your GI circulation, leading to decrease in blood flow and therefore decrease in production of your lymphatic fluid, thereby decreasing the volume again of your pleural effusion. The second goal is to relieve the patient's dyspnea. So initially, we do thoracentesis for these patients, and when we learn that the patient is actually having a chylothorax, then you might do pleuroperitoneal shunting. So we insert a tube coming from the pleural space into the peritoneum, so that you can return the nutrients that are found in your chyle back into the peritoneum. So CTT can actually be done. However, if you place the patient on prolonged tube thoracostomy, your patient will eventually develop malnutrition because he will lose the nutrients in the chyle, and eventually your patient will become immunocompromised because your fluid also contains some lymphocytes. So the third management is to treat the underlying problem, which is the thoracic duct. So you can actually do embolization or injection of a substance to close that leakage in the thoracic duct. You can ligate or suture the thoracic duct via VATS or open thoracotomy. You can also do clipping or placement of fibrin glue to the thoracic duct lip. Or if your patient is having a mediastinal lymphoma, they can also develop chylothorax. They might need to undergo radiotherapy. As mentioned, your pseudochylothorax is not due to the presence of your chyle. You will notice that the fluid is turbid, but this is because of the presence of cholesterol crystals, also known as your lecithin globulin complexes. So your cholesterol crystals are actually the generated RBCs or WBCs that were trapped in the pleural space. So these are prolonged effusions, now long-standing effusions that have been there for more than 5 years. So the cells that were trapped inside the pleural space eventually degenerate and become your cholesterol crystals. So most common cases are due to your TB, pleuritis. Others could be due to your rheumatoid pleuritis. very rarely you can have your paragonimiasis caused by your Paragonimus westermani, which is a lung fluke. So treatment, if your patient has TB, then you treat with the appropriate anti-TB regimen. And if your patient is symptomatic because of that pleural effusion, then you cannot just remove the pleural fluid. You might have to remove even the visceral pleura. No? So that surgical procedure is known as decortication. So removing that thick fibrotic visceral pleura will allow the underlying lung to expand if the underlying lung is still functional. Okay, so in your book, you have there a very long table showing you the different kinds of pleural effusion, and it's divided into your transudative effusions and your exudative effusions. Okay, so again, just remember that your transudative effusions are systemic, so your congestive heart failure, cirrhosis, and nephrotic syndromes can lead to your transudative effusions, while your exudative effusions are usually localized. They have inflammation. So neoplastic diseases, infectious diseases, your PE can either be exudative or transudative, your GI disease, collagen vascular disease, post-bypass, and other conditions that cause inflammation and therefore localized increase in your pleural fluid formation. Okay, so that is all for the pleural effusion. The next problem or disease entity we encounter in the pleura is your pneumothorax. So when we say pneumothorax, there is air or gas in your pleural space instead of the fluid in your effusion. So your pneumothorax can either be spontaneous, meaning there was no antecedent trauma or obvious cause, or it can be traumatic, meaning there was a direct or indirect trauma to the chest, or it could also be due to a therapeutic maneuver, such as your iatrogenic pneumothorax. So pneumothorax can be spontaneous, no underlying cause or trauma. It can either be primary spontaneous or secondary spontaneous. So your primary spontaneous pneumothorax can occur in otherwise healthy individuals. So they don't have any underlying lung disease. While your secondary spontaneous pneumothorax occurs as a complication of an underlying lung problem, mostly seen in your COPD patients. Okay? So your primary spontaneous pneumothorax actually comes from the rupture of apical subpleural blebs most of the time, and is seen almost exclusively in smokers. So they've seen that smokers can actually develop these apical subpleural blebs leading to their rupture. Okay? And it's found to recur in up to 50% of cases. So manifestations, this can occur usually in patients in their 20s, with main symptoms being chest pain, which is sudden or acute in onset, and ipsilateral or on the side of your pneumothorax. And your patient will also develop dyspnea, similar to the finding in your pleural effusion. Patients will be dyspneic because of the stretching of your muscles, respiratory muscles. Your primary spontaneous pneumothorax can actually develop even while at rest. So some patients, even if they're not doing any strenuous activity, can still develop your spontaneous pneumothorax. On physical examination, usually your vital signs are normal. On your chest, you would notice that there is asymmetry. So the side with pneumothorax will be larger and will move less during breathing. So tactile fremitus is absent and percussion will be hyperresonant. Your breath sounds will be reduced to absent. And you will notice for large pneumothoraces that there is tracheal deviation to the opposite side. So to diagnose, we get the history and physical examination, and we demonstrate the visceral pleural line by chest X-ray. So this is the visceral pleural line. Take note that you have here your lung parenchyma, and outside the visceral pleural line, there is an area devoid of your lung markings. So that is filled by air. That is your pneumothorax. Okay? So using your chest X-ray, we can actually get the percentage of your pneumothorax. We get the point uh, between the apex and the base of the lung, so that midpoint. Measure the width of your lung and compare it to the width of the hemithorax. Okay, so the formula is your 1 minus lung cube over hemithorax cube and multiply the value by 100 to get the percent. So the treatment goals for a patient having primary spontaneous pneumothorax is obviously to get rid of the air in your pleural space and also to decrease the likelihood of recurrence. So options, observation, supplemental oxygen, simple aspiration, CTT with or without your pleurodesis, VATS, and finally open thoracotomy. So your pleural air or pneumothorax can actually be absorbed at a rate of 1.25% per 24 hours. Meaning if you have a pneumothorax of around 20%, this can actually resolve in around 16 days by mere observation. Therefore, if your patient with a primary spontaneous pneumothorax only has a pneumothorax less than 15%, we can actually just observe these patients. But ideally, we admit the patient and give them supplemental oxygen. Your oxygen increases the rate of pleural reabsorption. This is because the air that we usually breathe is mainly composed of nitrogen. Oxygen is only 21% of air. Therefore, the air in your pneumothorax is mainly nitrogen. And if you give the patient 100% oxygen or a high flow oxygen, then this will blow off the nitrogen in the patient's lungs, and therefore you will have a greater gradient between a difference between the amount of nitrogen in the pleural space and the lungs, no? And therefore this causes diffusion of the air in your pleural space into the lungs of the patient. Okay, so you have faster reabsorption. Another option is to do simple aspiration. So if your patient has a pneumothorax of more than 15%, then we subject the patient to aspiration. So a needle is inserted into the second ICS anteriorly, and this has a success rate of about 60%. If the simple aspiration is unsuccessful, then the patient might have to undergo VATS or CTT. However, if your patient has a secondary spontaneous pneumothorax or a recurrent primary spontaneous pneumothorax, then we avoid doing simple aspiration and proceed with the CTT or VATS. Okay, so your CTT, your closed tube thoracostomy, is recommended if your simple aspiration is ineffective and your thoracoscopy or VATS is not yet available. So the tube is inserted through the ribs into the pleural space and allows the drainage of the air. And we check if the lung has expanded by doing a repeat chest x-ray and observe for the presence of bubbling or your air leak on the CTT bottle. So if you notice on x-ray that the lung has expanded and there is no longer any bubbling from the CTT bottle, then you can remove the CTT. However, if the air leak persists, if there is still bubbling even after 72 hours, then you might consider doing your VATS or your open surgery. Another option is to do your pleurolysis. So if you've inserted the CTT, before removing that CTT, then you might inject a sclerosing agent or pleurodising agent so that you can oppose or cause the adhesion of your visceral and parietal pleura to try to prevent the reoccurrence of your pneumothorax. So we usually use two agents, your doxycycline and your talc-slurry. So this pleurodesis can actually reduce the recurrence rate from 40% to just 25% in these patients. However, this procedure can have some rare complications. If you use talc, especially if it's not medical grade, then your patient might develop ARDS. The talc can enter from the pleura into the lungs and cause irritation, leading to ARDS. But the more common complication is pain, and this is more commonly seen if you're using a doxycycline as an agent. So another option for treatment is your VATS or your thoracoscopy. So this is the treatment of choice if your patient has had recurrent pneumothorax or if you did simple aspiration but was not successful. So when we do VATS, they can do stapling or suturing of that bleb to prevent reoccurrence. And they can also do abrasion of the pleura so that there will be adhesion or pleurodesis. So follow-up is usually 1 year after the procedure since that is the time that we expect possible recurrence. The duration of hospital stay is actually shorter, only 3 days compared to your open surgery. So the last resort for treatment is your open surgery. So this is recommended only if VATS is not available. So they do usually a lateral incision, open up the hemothorax, remove the air, and they do sewing of the blebs as well as pleural abrasion. So this is said to be very effective in preventing recurrence. Your secondary spontaneous pneumothorax, on the other hand, is more commonly seen in your COPD patients. It's said to be more life-threatening than your primary spontaneous because these patients already lack pulmonary reserve. They already have an underlying pulmonary problem, and then they develop your pneumothorax, which is an added insult to their depleted pulmonary reserve. Okay, so nearly all patients are treated initially with your CTT so that you have an immediate management of your pneumothorax. And subsequently, most should undergo your VATS or thoracostomy. However, if the patient is a poor surgical candidate, then they might opt to just do a pleurodesis. Okay, so next you have your traumatic pneumothorax. So traumatic meaning there was injury. So it can either be penetrating trauma. For example, if you have an open wound that allows entry of air into the pleural space, such as your stab wounds or gunshot wounds. So that's your penetrating chest trauma. Your non-penetrating chest trauma is due to alveolar rupture with dissection of air towards the visceral pleura, such as what happens when you have vehicular accidents. So when you have a vehicular accident leading to your blunt force trauma, this leads to sometimes rib fracture, sometimes um, compression of the lung parenchyma, leading to your alveolar rupture and pneumothorax. So to diagnose your traumatic pneumothorax, we usually request for both chest X-ray and CT scan. No? The problem with your traumatic pneumothorax is it can be occult, meaning your pneumothorax can be seen only by CT, not by chest X-ray. No? Take note, around 40% of your traumatic pneumothoraxes can actually be occult. So therefore, you have to request for chest CT scan for these patients. So management, we insert a closed tube thoracostomy. However, if your CTT is unsuccessful, the lung remains unexpanded, or there is a persistent air leak, then VATS is your second option. Iatrogenic pneumothorax is a type of your traumatic pneumothorax which is due to medical procedures. No? The most common causes of which are your transthoracic needle aspiration biopsy, your thoracentesis, as well as the insertion of central IV catheters. So for iatrogenic cases, we usually are not so worried about recurrence, no, since this is due to a procedure. So the management is similar to your primary spontaneous pneumothorax. You can just give the patient your supplemental oxygen or do simple aspiration. Okay. So next you have your tension pneumothorax. So in tension pneumothorax, the pressure inside the pleural space actually exceeds the atmospheric pressure. So you have a very high pressure in your pleural space, and this leads to compression of your mediastinum and eventually a decrease in the patient's cardiac output. So this can happen during your CPR or resuscitation, or if the patient is on mechanical ventilation with positive pressure ventilation. So on physical examination, you would notice that the patient has an enlarged hemithorax. There is no breath sounds on auscultation, hyperresonance on percussion, and there is a shifting of the mediastinum to the contralateral side. So this is a medical emergency, if you see tension pneumothorax. Therefore, you would need to do immediate needle aspiration by inserting a large bore needle into the second intercostal space anteriorly. And this aspiration is followed by the CTT insertion. So the CTT is left in place until you have resolved the pneumothorax of the patient. Okay, that is all for your disorders of the pleura. Thank you.